All right. Well, again, I am Amanda Vega, and thank you all for joining me today for my Master's of Professional Science in Biomedical and Health Informatics internship presentation. And today I'll be presenting ERIC 2.0, creating a database for atherosclerosis risk in communities. Now, a little background about myself. I am currently working with Wake Forest Baptist Health as an associate project manager. And I started with this study about 3 years ago as a data abstractor. And then in my second year, I began to lead the death process for the annual follow-up team at Forsyth site. So today I'll start by briefly introducing the study, and then I will discuss the current problem. And so you may all have a better understanding. I will provide some background on the study and the process of the data collecting, sharing, specifically looking at how deaths are handled within our study. Next, I will walk you through the database design, and last, we will go over conclusions and recommendations. So ERIC is one of the most significant and longest running heart health studies and is the largest study of heart health among African Americans. Funded by the National Heart, Lung, and Blood Institute of NIH, the ERIC study began in 1987 with approximately 16,000 participants aged 45 through 65 years, recruited from 4 communities, Forsyth County being one of which. And then now in 2021, we had around approximately 6,000 active participants, now in their 80s and 90s. And as years progress and continue, our participants continue to expire, which is why it's pertinent for us to be able to efficiently record and manage the deaths of our participants. On this slide, you'll see just the study design. The green is the timeline for the cohort exams, or for us, we know them as clinical visits. And then below that is the annual follow-up data timeline, data collection timeline, and you'll hear me refer to annual follow-up as AFU. And what that is it's a team that consists of data collectors who will conduct health questionnaires by phone, either one time annually or 2 times a year, 6 months apart. And then below this, you can see the surveillance outcomes from cohort and community. So our current problem for many years, data at ERIC Forsyth site for the AFU team has been tracked and communicated through multiple Excel spreadsheets. This often gets troublesome, especially when there's no designated location for these spreadsheets and multiple people are accessing them at times. And anyone is able to pretty much create a data Excel spreadsheet and change the current ones and manipulate them, causing duplicates, missing data, whether they're storing it in a different location or they're just simply deleting them. This has also been seen multiple times throughout the years at ERIC because of staff turnover. So there are several processes through ERIC, but for this project, I will be focusing specifically on the death process of our participants. So here's a flow of the actual death process from how deaths are discovered, reported, abstracted, and closed. Upon discovery through either obituary, informant, surveillance, DEC at that time, DEC form is open under our cohort side of our data management system that we call CDART, which is actually managed through UNC Chapel Hill's Collaborative Studies Coordinating Center. The DEC form is not only used as an initial death event notification to our coordinating center, but it also prompts the AFU interviewer to conduct a brief interview with the proxy or designated loved one to identify death location at any health events that occurred prior to their passing. And although the form is started, an interviewer contact with proxy usually will not occur and won't be completed until 3 months of allotted grievance time has passed. And then during this time, a designated staff member obtains a certified or uncertified death certificate, either from the loved one or the vital vital records office in which the person had passed. This is needed to officially record the passing of a participant. And then that's also put into the surveillance side of CDART, which we call a DTH form. And then the physical death certificate is actually sent to a certified coder to code the cause of death. And then we get that back and we put it into the CEL form, which is also under the ERIC surveillance and CDART. And then this will calculate if further forms are needed or if an IFI needs to be conducted. An IFI pretty much is an in-depth interview with, again, a proxy or someone that had a contact with the participant prior to passing, just regarding specific circumstances around the participant's deaths. And this is usually conducted by a specially certified interviewer. But both the DTH and CEL will also disclose to us if this was an in-hospital or out-of-hospital or in-county or out-of-county death. And then that way we can officially close the many years of participation that the participant has had with the ERIC study. All right, and the first phase of database design was the requirements and analysis. The AFU surveillance team was currently using and tracing, again, through 5 main Excel spreadsheets. The AFU team records the event on the death spreadsheet, and then they'll record it once again to the AFU to surveillance spreadsheet, which will just be used to trace the forms, and then again on an AFU to CC or AFU to coordinating center spreadsheet, which records the death as an event, and also surveillance will use to monitor for in-hospital deaths. So ERIC 2.0 was created and evaluated using these 5 characteristics: data integrity, data independence, data redundancy, data security, and data maintenance. And then on the right, you will see that I have displayed a relational schema of the 3 of the current main Excel spreadsheets that I had took you through. And this allowed me to identify all the redundancy as well as review the current practices. So you can see how many of the fields were carried over to each spreadsheet. All right, and continuing in the requirements and analysis phase, seeing the schema, I did realize that the 3 Excel spreadsheets, again, could be condensed into one single database or table. If the AFU and surveillance is able to track the process through this single database and record in CDART in a timely manner, I could completely eliminate the need for the AFU to coordinating center spreadsheet, since CDART technically tracks the forms for the coordinating center. So that eliminates coordinating center as a user. And then our primary keys in this database and all future tables that may be linked to the ERIC 2.0 would consist of the ERIC ID. And what that is that it's the first letter of our site, or any site, any of our 4 sites. In our case, it would be an F, and then followed by 6 digits. Each of these IDs are unique and assigned to one individual participant. I then met with each of our teams to identify the key information and practice that should be included, which is represented in the table seen here below. All right, and then moving into the database design, I needed to determine what program would be best to design the database. And Microsoft Access tends to be the better choice for data management because it has the relational database, as well as good storage capacity and data intake forms, along with data types. However, Microsoft Access does tend to be more advanced than Excel and can be difficult to learn. And also security is questionable when you're not using an additional front-end application, but that didn't apply to us as we do use a front-end server. And although Access can be used by multiple users at the same time, this can also become complicated and unsecure. And then Excel is a better used usually for data analysis. 1, because data visualization, and 2, because the simplicity makes it much easier to learn. But unfortunately, the lack of relational worksheets means that we can't link the worksheets by relation, and the lack of data integrity, which allows users to enter whatever they'd like into a cell. But after conducting a user survey, which asked team members to perform simple tasks in each program, as well as inquiring about the comfortability and knowledge with each program, I had discovered that only one person had slight knowledge of Access and that all of the team preferred Excel. This discovery, however, was learned a little later in the stage of implementation, after I had already designed and attempted to implement ERIC 2.0 using Microsoft Access. So knowing that the users were more comfortable with Excel and a lot of them did struggle in the implementation, I started back at the design phase and initiated design in Excel, which I was able to design the ERIC 2.0 in Excel, with Excel. So to protect the privacy of our participants, below is displayed a prototype and not the actual ERIC 2.0 database that's currently in use. Of course, the actual database itself has more participant entries and is more accurate. Right, and then starting with the design, after I identified the attributes that were entered, I wanted an easy way for a user to quickly be able to enter in the death, as well as be able to individually view this specific participant. This also, the easy entry form that I added also allowed the AFU or data abstractor or collector to assure all possible fields were entered in. Then I wanted to add conditional formatting, and we did this with a key that distinguished out-of-county and out-of-state death certificates, making it easier for the designated team member who retrieves our records to know immediately what vital records office they should be in contact with. And then for action words, identifying the status of the form, such as requested, needed, completed, were also assigned color formatting for quick and easy recognition. Conditional formatting was also assigned to identify duplicates as red, and because other fields such as names and dates will occasionally be the same, the formatting was specified to only the primary key, or in this case, the ERIC ID. And this again will allow users to remove duplicates all at once, and we'll just leave the remaining unique ones. And then for the last thing, I wanted to make sure that the database was secure by encrypting the workbook and requiring a specific password to access and edit. This not only protected the participant data, but also limited the access to those with password and only allowed a single user to edit at a time. And then we move into the database design implementation, usability and testing and training. For that, we did 3 AFU staff members, and they were asked to complete the following tasks seen on the right. They completed with an average of 4 to 5 tasks with medium or slight difficulty. Then they were asked to attend a 1-hour training, which they were showed basic instruction on common tasks, as well as introduced more difficult tasks, such as running queries, merges, and pivot tables. After training, they were again asked to complete the 5 tasks, which they were able to complete all 5 tasks with easy or no difficulty. And then for conclusions and recommendations, by analyzing the data and the process being used, we were able to identify and eliminate redundancy prior to even the database creation, which told us that much of our issue was within our process and not really specific to the spreadsheets that were in use. Another thing that we had learned was, again, always assess the knowledge of users prior to creating a database. We had what was called a scope creep, and it put us behind a little bit. Luckily, though, it didn't affect any sort of cost or budget. It just affected the project schedule and time and labor. And then the last thing we had learned is, again, simple modifications in both the process as well as the database can go a long way. Although these changes in the Excel spreadsheets may seem minor, just simply evaluating the data, putting it in there correctly, and having easier formats, it brought the progress of cut our time down by a lot. Now, our recommendations for the future ERIC 2.0 is we will assess the death reporting numbers in 6 months to evaluate the effectiveness of ERIC 2.0. And then we will also include relationships among tables within Excel for the death process for surveillance, because although Excel doesn't allow the creation of relational database, we can still cross-reference and cross-link different tables and pull all that data into a master table. And then for overall, we would like the use of ERIC 2.0 for all ERIC data and not only death-specific data. I do want to thank you guys all for joining me. I want to give a special thanks to, again, Katrina McDaniel, who was my mentorship, as well as Lisa Reeves from the Coordinating Center, who had put up with me requesting all the data. If you guys have any questions, please feel free to ask.